Don't have time now, so we'll request Dr. Murali to clarify. In the end, if we have some time left, we'll catch Dr. Nayak for that. Because I know there are too many questions on that, but we have to let Dr. Murali. He is a well-known glaucoma surgeon from Chennai, owning his own center, and he's always in the forefront, always trying newer things and newer technologies. But here he'll tell us whether Dorzolamide is improving the OBF in open-angle glaucoma patient. And please clarify for us whether it is also brinzolamide or only this thing.
Yeah, this is a simpler session. So thank you for inviting me and this nice symposium in which we have the president and the secretary of the GSI. So it's a real privilege and pleasure to be here. And of course, the AIOC, in the midst of the AIOC conference. I'm going to talk about, I think so far you've been listening to diagnosis, so the disc and field and OCTs and so on. I'm going to switch gears totally. This is completely different from what you've been hearing so far. This is looking at one single drug and seeing how it's actually affecting or maybe influencing the way we can manage glaucoma. IOP elevation, major risk factor for glaucoma, we know that. Many people with glaucoma will progress despite having so-called target pressures. And very large population trials have shown the necessity of and the importance of ocular perfusion pressure, and ocular blood flow alterations have been associated with glaucoma. It's not just the intraocular pressure, we all know that. And previous studies have reported that the CA inhibitor like Dorzolamide is probably effective in improving ocular blood flow, but there are very, very few or nil in Indian studies on the subject. So the various methods, how do you actually look at the ocular blood flow? How do you know what's happening in the back of the eye? Do you want to look at the circulation and so on? There's so many methods, so many tests are available, and all of them are research tools, and the ones which have commonly been used are the color Doppler imaging, which looks actually at velocity, and the flow is actually not measured. That's what I'm going to talk about. That's what we had the widest experience with. All the other machines, some of them are available. The new one to catch on is the Doppler OCT, which is popular in many countries. A lot of work is going on, but I think oximetry is another one. So many of them are not available in many centers, most centers. So our study looked at the normative data of the retrobulbar ocular blood flow using color Doppler imaging, and also to determine the efficacy of 2% Dorzolamide in improving changing things in the back of the eye in an Indian setting. And there were 24 healthy subjects, 19 glaucoma patients, open angle, moderate, 40 years and above. And the baseline ocular blood flow was done by a qualified radiologist who looked at the all participants underwent the baseline CDI. And for all glaucoma patients, the baseline CDI was followed up with three times Dorzolamide eye drops only. And subsequently, at the 12th week, the CDI measurements were taken by the same observer in the same setting. The final measurements were done at the end of 12 weeks. And the primary endpoint was the change in the color Doppler imaging parameters of the retrobulbar vessels, as well as the ocular perfusion pressure post-treatment. And the secondary endpoint, of course, was the mean change in the intraocular pressure and any adverse ocular events that were observed. This is the machine, and this is how the printout from color Doppler imaging will look like. I think all of you are familiar with printouts from the blood supply of the carotids and other arteries and vessels and so on. So this is how it looks like. You have the PSV, you have the EDV, you have the resistive index. Some of them are calculated, some of them are measured. So this is how, and this comes under the purview of the radiologist. We cannot do these tests because it comes under the PCP Act. The machines are used for obstetric scans. So we don't venture into doing these scans yourself. Even though you may be proficient, don't do it yourself. I'm going to show you a short video clip of how some of you may not be aware of how the color Doppler imaging is actually done. This is done by our radiologist, the crack radiologist we have. He is able to pick up the posterior ciliary arteries, the temporal or the nasal. He can do it in a flash. Whereas most radiologists will be suffering and struggling to get the measurements done. And we also had Professor Alan Harris, who came to us. He's the world authority on ocular blood flow. He was there with us to handhold and train us, and he actually gave us the protocol for the study. So this was the basically, I think the audio is not there. What he is trying to tell you is that this is called the duplex mode, and then you have the triplex mode, and then you also have what is called as the angle correction for the measurement for the Doppler. So it's a very highly technical, specific skill which the radiologist only can do, but you can understand it over time. So I think I'll go forward a little bit to show you what exactly we are seeing. This is the probe that is placed. You can actually do it in the sitting posture, or reclining posture, or the lying down posture, whichever is comfortable to the radiologist and the patient. But the same methodology must be used every time. So as you can see the measurements which are coming in there, you can see this is the ophthalmic artery, then you get the CRA, you can also get the temporal and nasal short posterior ciliary vessels. Usually he gets it quite easily. So it should not be a problem. And some of them, this is actually what is called, you can see the vessels there at the back. You can each identify the veins as well as the vessels easily. And once you get that, this is actually what is called as a reversal of flow. So this happens very rarely, but this is actually what is called as a reversal of flow. So just to show you a few examples what I said. The patients who were included for this study were treatment naive and patients more than 40 years of age, mild to moderate glaucoma, at least one eye. Patients willing for follow-up in 12 weeks. Normal healthy volunteers had no ocular abnormality, normal optic disc, and IOP less than 21 in both eyes. This was a normative data. We excluded secondary glaucomas, excluded severe uncontrolled metabolic and cardiovascular diseases, intraocular surgeries, previous SLT, ALT, and previous inflammation, any steroids, any kind of systemic medication that used to control the blood pressure and intraocular pressure were not used. The patients were not taken for the study. The patients who would not come for follow-up, we had excluded them. And of course, the allergy to Dorzox or pregnant patients were excluded from the study. And the first publication of ours actually came out in 2021, which looked at the normative data. We didn't have normative data for us to compare and say, this is what do we compare with? We are taking some measurements and you're saying this is normal or abnormal. So we first published a normative data of the ocular blood flow using color Doppler imaging in South India. This was in 2021. And this is the normative data. We looked at the ophthalmic artery, the CRA, and the posterior ciliary artery. We looked at different age groups, and we of course calculated the resistive index as well. This is the normative data for South India, at least what we did in our center. And we also looked at the normative data in the same group of patients with the ocular perfusion pressure. We also looked at the resistive index and the intraocular pressure in this same population. And to sum up in brief about our Dorzox study, which we had compared the clinical parameters between baseline and 12 weeks. You can look at all of the yellow highlighted ones. After 12 weeks of treatment with 2% Dorzolamide, the significant improvement in the ocular perfusion pressure, statistically significant increase in the end diastolic velocity in all the major arteries, especially the SPCA, and also a significant reduction in the IOP after Dorzolamide 2% treatment. And no adverse events were reported in this very short time of 12 weeks. So these are the results of the ocular perfusion pressure, which we compared between normals and the glaucoma patients. This is the mean ocular perfusion pressure. The glaucoma patients showed significantly reduced baseline ocular perfusion pressure as compared to the normals. So the prevalence and progression of glaucoma is often related to low ocular perfusion pressure. Open angle glaucoma is associated with the decreased mean blood flow velocity and increased mean RI in the central little artery and the SPCA, short posterior ciliary vessels. Topical CAs have been proven to increase the ocular blood flow, but however, their effect on the Indian glaucoma patients has not been well studied so far. And in our study, the evidence of increased OPP and EDV with Dorzolamide retrobulb could be an IOP independent effect. It could be the direct metabolic effect of the Dorzolamide on the blood vessels, a carbon dioxide mediated vasorelaxing effect. It could also, of course, be the blockade of the CA inhibition in the local tissues, increases the ocular perfusion pressure via the IOP mechanism. So you can actually, this is only a hypothesis that it's possible that the IOP lowering as well as the CA inhibition with the direct metabolic effect on the blood supply has actually increased the blood. So we don't really know for sure which actually is the beneficial part. And color Doppler imaging, mind you, has a lot of limitations and pitfalls. Cannot be interpreted as blood flow values unless the diameter of the vessel is also specified. CDI measurements depend on the probe position and the Doppler angle. The measurements have to be accurate and on the dot. The long ciliary artery is often mistaken for the short posterior vessel, so you need to know your so-called how you image the back of the eye. And the reproducibility between different operators is acceptable to a certain vessel or parameter, but not good for the back of the eye. So you need to know somebody who has been trained well to look at the back of the eye. So not everybody can look at the back of the eye and get you consistent results. So a radiologist is definitely required. Systemic diseases, treatment for blood pressure, and patient comes in rushing, tired, anxious. Give some time, let them relax for some time, and then do the measurement. Don't do it immediately when they come in with borderline BPs and low BPs and so on. So conclusions, Indian glaucoma patients have significantly a lower ocular perfusion pressure compared to healthy subjects. Topical Dorzolamide has definitely reduces the improves ocular blood perfusion and increase in the end diastolic velocity, the most of the major retrobulbar vessels. This is the first Indian trial to evaluate the effects of Dorzolamide in glaucoma patients, where we found there's a significant improvement in the ocular blood flow at the back of the eye. But mind you, it remains to be established whether the above mentioned effects on the ocular blood flow at the back of the eye can be helping the patient in visual field loss Can it stop the visual field progression? Can it actually improve the glaucoma? It's a different question altogether. We only looked at one parameter of the blood flow. It's the interpretation, and this is something like a future study which would probably show us what actually is happening to dorzolamide treated patients. It's a difficult study to do because invariably it's an adjunct. So you don't give a primary drug like dorzolamide for most of our patients. This is from Alan Harris' book on ocular blood flow. We look at the number of studies which actually looked at in literature published so far about dorzolamide and improving ocular blood flow. This was published in the World Glaucoma Consensus book by him, Alan Harris, the ocular blood flow and glaucoma. The entire references are available in the book. And the recent survey of ophthalmology has a very good summary and survey of a major review of literature review on meta-analysis of topical CA inhibitors in ocular blood flow. The data suggests that dorzolamide added to timolol may actually be effective in preventing progression of visual fields, in addition to increasing the ocular blood flow and reducing intraocular pressure. So we do have some data, some meta-analysis published in an international review journal which suggests that possibly there is some indication of glaucoma progression being halted. So in conclusion, the meta-analysis implies increased blood flow velocity and decreased vascular resistance in the retrobulbar vessels during CA inhibition. And we went on to publish our data. And the first paper which we presented during the 2022 in the AIOS, that got us the best paper, the glaucoma, DB Disha Glaucoma Award that time, 22. And now we have published this in the IGO. This was published last year. And I'm happy to inform you that the IGO has just informed us and we're getting an award this evening. This has got the IGO Silver Award for the best publication, best few publications in 2022. So this is the IGO publication. Thank you. And what I would like to say in this slide is that the improving ocular blood flow in conjunction with lowering intraocular pressure is the way to go. You cannot primarily look at ocular blood flow as the only way we can treat glaucoma. So dorzolamide seems to be doing both. So that's the way we say that since dorzolamide blocks the transformation of carbon dioxide to bicarbonate, it produces a dual effect of increasing carbon dioxide in the eye, improves ocular blood flow, and less bicarbonate in the eye leads to reduced aqueous production, therefore lowering IOP. So we have a dual advantage of probably doing both, but we need a lot of studies to tell us what exactly would happen to glaucoma patients when you use dorzolamide in terms of blood flow and so on. It's a difficult test study to do. Like the one which we have done also took us about 5 to 6 years to complete. So take-home message for all of you who are practicing clinicians, that's a basic theme of the General Ophthalmology Symposium today, is not to confuse you with high-tech research and color Doppler imaging and so on. 24-hour BP monitoring does have a value in terms of normal tension glaucoma and select glaucoma patients. Ocular perfusion pressure and OBF studies are useful in select patients. Don't go away the impression you need it for every glaucoma patient. CDA is an established tool but has many limitations in doing it. You can't do it in every center in your practice. The OCT angio seems to be a more recent development but is yet to be incorporated for routine clinical use for estimating these kind of blood flow parameters. The implication of ocular blood flow improvement by dorzox in glaucoma progression is our subject for future study. We have already put out the ethics committee approval for this study and the study is now ongoing. It will take a couple of years for us to come out with this data. I wish to thank my team, particularly the support from CIPLA, unstinting support from CIPLA since 2016 when Professor Alan Harris came in, and we also have people who came in wide across India to participate in the first hands-on workshop on ocular blood flow imaging at Chennai in 2016. Thereafter, we have conducted many more workshops, similar workshops with the radiologist, and we hope to take this forward. Thank you. Thank you for listening.
Thank you, Murali. Wonderfully summed up. I think that was nice. That last slide was very good. That what is the relevance for us? So what about the brinzolamide question?
The number of studies which have looked at dorzolamide and brinzolamide, there have been an overwhelming amount of literature on dorzolamide. Brinzolamide, there are a couple of studies which show that brinzolamide also does help. But the CA inhibition with the isoenzyme which the brinzolamide blocks is different from the one the dorzolamide does. Oh. So which is why the people say that maybe what is known in literature is what we treat. There is no clear evidence that brinzolamide also helps. Probably if you feel dorzolamide is not tolerated by a patient, you're probably not wrong in giving brinzolamide because the basic principle of inhibition of CA, carbonic inhibition is the same. 12 weeks, sir. 12 weeks. There is a protocol designed by the Indiana University. Thrice a day. It is given single drugs, it is given thrice a day. No, these were very selected patients who were followed up closely and were willing to come for follow-up. They had signed consent forms and so on.
I think only for the study
purpose. Almost 100% follow-up. We didn't lose the patients.
But he's shown that Timolol also helps. So
Yes.
they can give Dorzolamide, Timolol,
Absolutely.
BD.
So lowering intraocular pressure is the primary management of glaucoma. If you are seriously considering that ocular blood flow is an issue as far as glaucoma management is concerned, you need to keep this in the back of your mind. And if you really do have proof from, say, further study that Dorzolamide has clearly shown halting progression as compared to something else, then we'd probably be happier.
So one additional advantage of the CDI is that you can get the flows.
Yes.
So because my better half, she's also doing the OBF study. So many patients who are having hidden cardiac diseases, because
Okay.
you are getting aberrant vessels around the SPCA, so that you can see that okay, this is not a normal
Yes.
waveform.
You pick
and
up
then you
so
can,
much in vein occlusions,
so
diabetic
most,
retinopathy, so much of vasculature
around
abnormalities.
15
you
or
pick up
20
actually.
patients who are having
Yeah.
the carotid artery blockage and all that. Whenever you are doing a CDI, you tell the radiologist to do a carotid Doppler also.
Absolutely.
Request her.
We do that routinely. We ask
because
because it's only an extra few seconds for the
seconds, and then
radiologist.
you can just-
Look at the carotids as well, and they put it in free usually.
Yes, sir. Thank you, sir. Thank you very much.
Yeah. Bolo.
I just wanted to comment basically on OCT. We should make the technology our slaves and not become the slaves of technology. And for that, see, in glaucoma, in reference to glaucoma, what we need is that what is the purpose of these investigations? As I told in my talk, the purpose is basically to reduce the number of glaucoma suspects, because glaucoma suspect is because of the limitation of our diagnostic modalities and our brain, our clinical assessment. So it is deficiency in that. So that deficiency should be filled with, that we need to fill with, with the help of these investigations, and not adding more and more cases to the glaucoma suspect group. Because we have done this, we have found this mistake, so now this patient becomes glaucoma suspect. So we should not be adding glaucoma suspects, we should be reducing the number of glaucoma suspects and make this technology our slave. This is specifically more important for OCT.
I think it's a very, very relevant. May I add a comment here? Just yesterday, I think I was in a session in which there was a free paper session on use of AI using fundus photography in vision centers and so on. So multiple vision centers, it is run by the Arvind Hospital, Pondicherry, looking at multiple vision centers. You take the fundus picture using the camera. The AI looks at the picture and tells you, is it glaucoma suspect, or is it normal? So you have these three categories. And the specificity of that particular test and the particular picture which the AI, they have worked on quite a lot of images. Lots of images were put into that software. And it's amazing to see that it actually sort of really, like your question about seeing everybody by a glaucoma ophthalmologist or glaucoma specialist. You can have vision centers using the simple technology, take a picture, assess and exclude glaucoma. Say if it is normal, then those people don't come for further evaluation. If it is abnormal or suspect, that's when they need to come in for further, and that sort of reduces the burden and maybe increases the detection rate for glaucoma. Maybe the future could be in AI.
Thank you very much, everybody. I think that was wonderfully done, and I think we have